So our next speaker is Mickey Collins. He's world-renowned in the area of sports concussion. He serves as the executive director and founding member of the UPMC Sports Medicine Concussion Program. His expertise attracts elite and professional athletes from all over the world seeking the comprehensive care that he provides and the multidisciplinary approach that he helped to introduce. Mickey and his UPMC program colleagues see dozens of patients every day, including youth, high school, collegiate and professional athletes from all walks of life. Mickey Collins.
Good morning. It's an honor and pleasure to be here. It's great to be back to your beautiful country, home, and my heritage is from here, way back, and it's just it's nice to be here. I love it in Dublin and Ireland. And I also want to thank the GAA and Bon Secours for having this event. It's very clear the GAA is committed to the welfare of their athletes, and to have this conference and to build upon what we did last year is very exciting. We appreciate the opportunity. And I also think this is good timing right now to kind of switch gears to talking about managing an injury that is tangible, that we have made progress on. If there's anything I learned in those first two lectures, there's a lot to learn about what the potential, and I underscore potential long-term effects are of this injury. What I'm here to discuss is really an injury that presents itself, and how do we treat that problem, and how do we get kids back to the sports that they love. And you'll be hearing from myself and the rest of our group pertaining to that for the next however long. So before I start, I wanted to disclose that I'm a co-founder and stakeholder of Impact. I will be discussing that tool a little bit today, but there's way more to managing concussion than this tool, and we'll be sharing that information as well. So really, the talk I'm going to deliver this morning is really building upon the model I at least presented in cursory form last year. And what I would like to discuss is how we're learning truly that concussion is a heterogeneous event. If there's 30 different types of knee injuries, why do we think there's one type of concussion? We're starting to see that there's different phenotypes of this injury. And if you match the certain problem with certain treatments, we can see improved outcomes in our patients. I'm going to really get into depth this morning about how we assess these different clinical profiles and what findings in our exam and our tools lead us to understand if we're dealing with certain different profiles of injury. And then, of course, once we can assess that and use our tools to determine what type of concussion we're dealing with, what treatments do we do and employ to better the outcomes from our patients. And really how clinical management, treatment, and rehab directives are very heterogeneous, just like the injury itself. I guess what I'm trying to say is concussion management is about process. It's not about protocol. You got to look at the individual and treat the individual, and I think that's a very important discussion point. So I think it makes sense that this is a very heterogeneous event. The brain is extremely complicated. We have, if there's anything we're learning, and you learned today from Anthony, is that it may not be how hard you get hit in the head, but what you bring to the table when you get hit in the head as to who gets concussions and who have the longer term outcome difficulties. We all have different pre-existing risk factors. We all have different psychological characteristics. There's different injury biomechanics. There's a lot of different symptoms of concussion. There's 20, 21, 22 different symptoms of concussion, and some patients have a few of those symptoms. Some patients have all of them. But they range across, physical, cognitive, sleep, and mood domains. And at the end of the day, I think it really behooves us as clinicians to start looking at this injury in a heterogeneous fashion and to realize that there's not one uniform way of treating concussion. To that end, we've started to develop tools. We've developed tools that lead us to understand the heterogeneity of this injury. And there is no biomarker for concussion. There's no blood test. There's no saliva test. There's nothing currently available, nor do I see anything available in the near future that is going to, you have a concussion, this is the type of concussion you have. We as clinicians are left with developing and using tools that get us to the problem. And a good clinical evaluation is what needs to happen with these children and others that have head injury. Now, when we look at this injury from our perspective, we need to look at multiple domains to better understand the type of concussion the patient has. and we're going to look at neurocognitive function. We're going to look at how the patient responds to exertion. We're going to look at the different symptoms the patient's having, and we're also going to look at the domains, vestibular domains and oculomotor domains. To us, in putting this information together, that's when you can confirm diagnosis, confirm or help understand prognosis, and then match the right treatment to the right problem. And we've developed tools that allow us to screen for these issues, and then we have more thorough assessments that can occur as well. I wanted to discuss briefly computerized neurocognitive testing. That is a tool that's been around for quite a while. It's the only FDA-approved tool that we have to look at concussion. And there are several really good computerized neurocognitive test tools on the market. All of them have research to support their use. The tool that we're involved with is Impact, and that is, we have a tool that ranges down to age 5 to 11 called Pediatric Impact, and then a tool that ranges from ages 11 to 60. There's over 250 peer-reviewed papers in this tool. The sensitivity, specificity, added value, reliability, et cetera, has all been well vetted. And again, that's the one tool that's been FDA approved to look at, to use for concussion. I am going to be talking about how we use this data to understand what type of concussion we're dealing with. And again, it's a piece of information. If you think we manage concussion only by looking at an impact report, that's not correct. We're going to look at impact, we're going to look at symptoms, we're going to look at the VOMs, all these different things to identify what type of concussion. And by the end of my lectures today, you'll probably have a good understanding that there's different cognitive profiles that match different types of concussions that we see. And I'll give you a flavor of that as we go. But clearly, having an objective way of looking at this injury through computerized neurocognitive testing is very important. It's also important to understand that baseline testing is very important as well to understand where the athlete stands before they have an injury. In the United States, at least in Pittsburgh, I don't think there's a kid in high school that doesn't have a baseline, and there's hundreds of thousands of kids across the country that are doing baseline testing in the United States. It's mandated in the NFL, NHL, and many other sports. That information does prove very helpful to us as clinicians, so when there's an injury, we understand where the patient should have been, and then use that as a comparison point to look at recovery. I think it's very intuitive to think of it that way. When we have a baseline available to us, and this can be done by physios, it can be done in clinics, it can be done in schools, it can be done in a very efficient way, but when we have baseline testing and then there's an injury, we actually feel the earlier we can see these kids, the better, because once you identify the type of concussion the patient has, you can actually initiate treatments right out of the chutes and get these patients better quicker. You know, I talked last year about, there was a lot of discussion about on-pitch evaluation of concussion, and I think that is a very important topic. But in my mind, that's where the work begins. The on-field stuff is fairly easy. If there's symptoms, signs of injury, patient's taken out of play, the work begins at that point in terms of getting the patient in the right lane for treating the problems that they have and getting them healthy in an efficacious way. We like to see kids early on from the injury, and then there's subsequent time points of evaluation that can occur after, where treatment and rehab of injury can occur, and eventually to the point of return to play. So again, with neurocognitive testing, we have the ability to get baselines and then follow them up as needed after the injury. The other tool that we've developed at UPMC that allows us to get a better handle on concussion is looking at the vestibular and oculomotor systems, and we developed a brief screening tool called the VOMs. This is a 5-minute test. It's a physical examination where we're looking at vestibular ocular reflex, saccades, pursuits, visual motion sensitivity, near point of convergence. And what we do is before we do the exam, we ask the patient if they're having headache, dizziness, nausea, or fogginess. They rate it 0 to 10, and then we conduct different aspects of this exam, or conduct this exam to see if symptoms are provoked. We also look at, as many of you learned last year, how many of you were here last year for this conference? How many of you were not? Just a raise of hands. Okay. We went over in depth this exam last year, and Ann Muka is going to be discussing it a little more in depth as well. I think it's very important for you to understand that we have a very sensitive exam that can be conducted to look at whether there's vestibular and oculomotor issues related to concussion. And in fact, this exam at 6 days post-injury has a 90% positive predictive value in determining concussion in these patients. And it's a fairly straightforward exam, but there's a lot of meat on the bone in terms of understanding how that information applies to phenotyping concussion and understanding how to approach treatment. I'm going to be talking about this generally this morning, but you'll get a better flavor for it as the lectures go on this morning. But this exam is really, really important as it relates to evaluating this injury. Okay, so once we put this information together, we look at the neurocognitive data, we look at the vestibular aspects of the VOMs, the oculomotor aspects of the VOMs, and we look at symptoms and how patients respond to exertion. That's when we can really identify diagnosis and prognosis. This is the only way to diagnose concussion is by looking at these different tools. Not a single tool is going to be used, like you have a concussion based upon this tool. It's an evaluation that needs to happen. Most importantly, after we understand diagnosis, we're starting to get a much better handle on prognosis, and there's a lot of really good research now supporting the fact that if you have this clinical profile or these sets of symptoms or have these risk factors, recovery is going to be longer than in kids that don't have those problems. And you'll be hearing a lot about that today from Anthony as well. But once we have this information, we can also understand clinical and treatment profiles. And that's really what my lecture is this morning, is to share with you that model and how we can identify these different types of injuries, what assessment findings lead to that profile, and how do we treat that problem. And then we can establish targeted treatment and rehab plan. Based upon the clinical profile, we can understand different academic considerations for the student athlete. And of course, the most important issue is getting these kids better so they can function not only in school, but also get back to the sports that they love, which we can do. There's very few patients. We have 20,000 patients a year to our clinic in Pittsburgh. I can tell you it's very rare that we won't get kids back to the sports in what we believe to be a very safe way and getting them back participating and functioning at a very high level. So our model that we look at with this injuries, we've really started to identify that there's 6 different clinical profiles of injury. Vestibular, which is the part of the brain that allows us to interpret movement, motion. We're not talking peripheral issues as much as we're talking centrally derived vestibular dysfunction that leads patients to have this slow, wavy, dizzy feeling, environmental sensitivity, feelings of fogginess, headache, fatigue. These are patients, when they move dynamically, they become symptomatic because the brain's ability to interpret movement and motion is housed within that system. And that's really where we're seeing a lot of these injuries break down, is that issue. We also have patients that have oculomotor dysfunction. I'm going to talk a lot about that. Patients with cognitive issues and fatigue issues, patients with migraine, patients with cervical problems, which can lead to some of these symptoms. And then we see patients with mood issues. Now, patients that come to us, when we evaluate this, they may have one of these circles, they may have 3 of these circles, they may have all 6 of these problems going on, but your treatment and how you approach managing and treating the patient is going to be predicated upon what circle or circles are present, and then you match the right treatment to the right problem. And there's really different treatments for each of these problems. I can tell you one thing though, rest does not help many of these issues. It's actually active treatment. And the international consensus statements with all respect, those statements have been great in terms of increasing awareness, in terms of creating a nomenclature for us to understand the injury, but there's been very little discussion about treatment of concussion, and that's what I want to discuss today, is how do we actually treat this problem. So there is a very robust, evolving literature understanding that there's different clinical profiles associated with concussion. And every day, it seems, there's a new study coming out pointing at the injury in this fashion. And again, this is not about protocol, it's about process. And if with the international consensus statements we have, manage concussion this way, I would argue that that's not possible because there's so many different presentations that we see with this problem. You have to manage the individual, not necessarily. Protocols are great in terms of understanding, but really to treat this injury properly, we have to identify what's actually happening and then treat that problem rather than looking at an injury in a homogeneous fashion. So one of the more important aspects of our research recently is understanding that each of these different clinical profiles have different risk factors. concussion at the end of the day is an energy problem. Potassium out of the cell, calcium into the cell. When potassium leaks out of the cells, an increased demand for glucose. When calcium leaks in, we get vasoconstriction and less cerebral blood flow. And concussion is an energy crisis to the neuron or cell. What we're learning is that what you bring to the table, concussion fights dirty. Whatever problem you bring to the table before the injury, that system's going to decompensate a lot more easily in that patient versus someone that doesn't have that problem, which makes a lot of sense. So for example, if you have a history of motion sensitivity, car sickness, how many of you in this room have a history of car sickness? I know when I came to Ireland with my 4 daughters several years ago on vacation, I was not here to do a lecture, I came here because I love your country. We landed in Dublin and we took a taxi where my wife and I and one child were sitting across, in the back seat from my other 3 children, and we were going the wrong way of traffic. To you, it's the right way. It's not the right way for us, okay? And we're just come off a jet airline, and it's in the morning. It's very early. And at the same time, all of my children vomited all over the taxi. And I felt so horrible for the taxi driver. I didn't know what to do. I'm like, can I help clean it up? He's like, just leave. And I'm like, okay. So anyhow, we have that a little bit in our family, the motion sickness issue. I don't know if it's just Ireland or not, but we do have some car sickness in our family, and it's not coincidence that the girls that have a history of car sickness in my family have all had concussions, and when they do have concussions, they have vestibular dysfunction. And the way we treat vestibular dysfunction is by rehabituating that system. If you have a history of motion sickness, you're more likely, because concussion is an energy problem, to go down the vestibular pathway of concussion. And how you treat that problem is by retraining it, rehabituating it, okay? That's just one example of the several research papers that we've published. If you have a history of lazy eye or strabismus or amblyopia, you're more likely to have oculomotor dysfunction following concussion. A history of learning disability, cognitive issues, a history of migraine, and if you have a history of anxiety, you're more likely to be anxious after concussion. Concussion fights dirty. And so when we talk about those accelerometers that was just discussed, we're not finding that it's how hard someone gets hit in the head, it's what you have before you get hit in the head as to what forces result in the injury. It's going to result, if you lined up 100 people and hit them in the head, these patients are going to go down first, and then they're going to have certain problems that manifest as a result of that. And it's how do you treat those problems is where the important conversation exists. So let's get into talking about what I want to do for the rest of my lecture here is to really break down these different circles and what assessment findings that we have that lead us to understand if a patient's having vestibular problems or oculomotor problems or migraine. And then I'm going to present one slide for each, what the assessment is for each of those circles, and one slide for treatment for each of those circles. And to take this to the next level in terms of sharing how we approach treatment in this injury. I do want to, again, reflect, however, on the fact that this model has not been proselytized from this international consensus statements. If you actually break down those international consensus statements, it's about rest, right? And in fact, if you progress someone and they have symptoms, you're supposed to take them back a stage, let them rest some more. I'm going to argue this morning that you're not going to get patients better very quickly if that's the route you choose to take in treating your patients, because the problems that I'm sharing with you need to be treated through rehabituation and retraining. It's not by doing nothing. And so as we understand more about the complexity of this injury, we understand that this is about process. It is about understanding what type of concussion the person has and how we match that active treatment to that problem. And really, the discussion that we need to really start to evolve is active and early treatments of concussion. And how can we improve our outcomes and get patients better by taking an active and early approach to managing the injury? So let's go through each of these circles and talk about what assessment findings lead us to fall into here and for each of these circles, and then how do we treat each of these problems. So the first one I want to talk about is vestibular dysfunction. And in our literature, we've found that 60% of youth and adolescents athletes with concussion will have vestibular symptoms following injury. In fact, how many of you realize that on-field dizziness is 6.5 times more likely predictive of the worst outcome from concussion than any other symptom? So if you have dizziness on the field, you're 6.5 times more likely to take a month or longer to recover from concussion. That's 6.5 times more likely than losing consciousness, by the way. Dizziness is the most predictive symptom for poor outcome from concussion. And it's not coincidence that a lot of the symptoms we see with vestibular dysfunction predict the worst outcomes. And that might be because up until recently, no one knew how to treat this problem or recognize this problem. I think as you see us evolve with our therapies and how we intervene more quickly with these patients, our outcomes are going to get a lot better and a lot faster and get patients back to play sooner. So when we're talking about a vestibular profile, there's certain risk factors. So again, patients with a history of motion sickness or car sickness are more likely to fall into this category. The symptoms we get from central vestibular dysfunction is you have this slow, wavy, dizzy feeling. That's brain. Quick, rapid vertigo, spinny dizziness is more ear. We're seeing much more slow, wavy dizziness than quick, spinny dizziness. Now, we can have peripheral vestibular problems in these patients, and Ann will talk about that, but it's more likely to be the centrally derived dizziness that's a slow and wavy type of feel. These are patients that walk down a busy hallway at school. They'll become dizzy. They'll get a headache. They go into the school cafeteria. They have to sort through a very busy environment. When patients move dynamically, in the United States as a quarterback, if you have a problem with this issue, they drop back in the pocket and scan the field, and that that horizontal vestibular-ocular reflex, that's where the symptoms are coming from. You're not going to get to this problem by doing treadmill testing. You're going to get to this problem by moving patients dynamically. And when that system is decompensated, that signal comes through aberrantly, and they feel this kind of slow, wavy dizziness, nausea, car sicky kind of feeling, okay? Some questions to ask of these patients. Do you get dizzy, foggy, or have a headache when looking up, down, turning head, walking down a busy hallway? Are symptoms provoked with dynamic movement? Now, when you look at our tools, the VOMs, you're going to find provocation to dizziness when you look at the VOR, either in horizontal directions or vertical directions, or visual motion sensitivity, where you're inhibiting vestibular-induced eye movements, looking at a target against a busy background. Again, Ann will go over this with you as to how we look at this in our exam, but that's where you pick it up on an exam. And we're actually finding that there's very specific cognitive profiles of patients with vestibular dysfunction on impact or neurocognitive testing. In fact, and this is high-level stuff, for those of you who never used this tool, I just want to share with you that we actually can look at the tool and understand if a patient's having vestibular problems by understanding the different deficits. And on impact, visual motor speed correlates with vestibular dysfunction. And so when you have a patient that comes in, they have a history of motion sickness, they're getting dizzy in busy environments, they're getting dizzy when they move dynamically, their VOR is provocative for symptoms, their VMS is provocative for symptoms, and you have visual motor speed deficits and impact. When it walks like a duck and quacks like a duck, it's usually a duck. And that's what I'm trying to get at, is that this is a different type of concussion. How do we treat vestibular problems? You treat it by exposure. You treat it by rehabituation. Rest is not going, we may quote unquote rest these patients for a day, 2 maybe, but if you really want to treat these patients, they're going to have symptoms. We want them to rehabituate to these environments. If they get dizzy in a hallway, we want them in a hallway. We just want the expose, recover model. So this whole understanding, how many of you in this room are, don't use computers when you have a concussion, don't go to school, sit in a dark room, don't exercise? How many of you, has that been discussed? That's sort of the model that's employed. That's not going to get these patients better very quickly. These are patients that actually need to retrain that system. And that's why we have physical therapy, such as vestibular therapy, to do that. And we have really sophisticated ways of providing physio and physiotherapy to these patients that have these issues. We also know that dynamic exertion is critical to understanding if these problems still exist. We've developed a standardized exertion test called an exit test that we use. When we clear a patient back to play, we don't clear them back to play unless they go through that test, because that will get to whether the patient's having any mild vestibular dysfunction that we couldn't pick up on in our exam or in the data. It's very important to make sure the system is rehabituated before you go back to play, or you're going to see a reoccurrence of problems again and again and again. If you treat concussion properly, that's the best form of prevention. And that discussion this morning, I would like to think that if you manage your patients better, we're not going to be as worried about some of those issues that were being discussed this morning. Certainly, the patients we're seeing getting back to play, if you treat it properly, we can mitigate poor outcomes, in our opinion, the great majority of the time. Now, there's some patients with vestibular dysfunction that end up with migraine, they end up with anxiety, they end up with sleep problems, and sometimes those problems are intractable, and until you get those problems under control, you're not going to get the patient over the hump. We see very complicated patients. They come from all over. Some patients have anxiety, some patients have migraine. Sometimes medication is important, and if you have a mood overlay, maybe we need to use an SSRI in some of these patients. If we have anxiety as an overlay, we may need to use Klonopin or clonazepam. We may need to use tricyclics if there's a migraine overlay. Sleep meds if there's a sleep overlay. There's a time and place for medication. Most of the patients we don't use medication on, but I wanted to share with you that we do have options pharmacologically to help some of these patients have chronic problems. We see patients that are a year or two post-injury that aren't better. We can still treat the great majority of these patients if you manage it correctly and target their problems with the right treatment. So the second profile I want to talk about was anxiety. Now, one thing I wanted to mention that I think more research needs to be done, and there could be some great collaboration here, is we actually find patients with anxiety have a lot of vestibular problems. And the vestibular system, if you look at the brain pathways, there's a lot of synergy between the vestibular pathways in the brain and the emotional pathways in the brain. And patients that end up with vestibular dysfunction, we see a lot of comorbid anxiety in those patients. We can see anxiety without vestibular dysfunction, and we can see anxiety with vestibular dysfunction. But if you think about it critically, patients that have vestibular dysfunction and anxiety, what ends up happening is a patient will then condition themselves when they're anxious not to do the things that make them feel the vestibular problems. And if you actually understand what I'm saying, they actually get further and further away from getting better because they're avoiding the things that make them feel it. That is a very common problem in our country, especially when you combine that with the hysteria that's being discussed around CTE, and people's anxieties are already so high with this injury. You can actually end up in a rabbit hole very quickly with these sets of issues, and we see it all the time. Patients with anxiety, we found, a family history of anxiety predicts post-traumatic or post-concussive anxiety. Parental dynamics play a huge role. If I walk into an exam room and the kid looks at their mother before they're answering my question every single time, there's definitely anxiety at play. If I have a mom that comes in or a dad that comes in with a big thick notebook, that's doom, doom and gloom. If I have parents that come in, the first question they ask is, does my kid have CTE, which happens way more than you realize, that creates a lot of anxiety. With all due respect to the first two lecturers, that's pretty nerve-wracking to listen to that lecture. I would like to think that we need to shift our conversation from creating fear and hysteria to creating this discussion that we actually have advanced our treatments with this injury. And sports are a great thing to relieve anxiety for kids as well. So we got to be mindful of those relationships and those issues. There's a lot we have to learn about CTE. There's nothing definitive in anything that was discussed. We have so much to learn about that. But right now, in this culture that we live in, people are very anxious about concussion. And that can create a lot worse outcomes following concussion if you're not mindful of that and know how to manage it. The symptoms we see: hypervigilance, difficulty initiating and maintaining sleep, self-limiting behaviors. We have patients that come in that won't go into shopping centers. They don't want to be in school because they're in environments that produce the vestibular dysfunction, and they don't want to be there. They're very self-limiting. Fatigue, attention, short-term memory problems. Some of the questions to ask for these patients: do you have a difficult time turning off your thoughts? Do you become symptomatic when thinking about your symptoms? One of the questions I should ask here is, are you an engineer? Because for some strange reason, engineers have a lot more anxiety with this stuff than other people that aren't engineers. Some of our Ivy League schools in the United States, some of the worst outcomes we see are kids that go to Harvard or Dartmouth or whatever that are very analytical. They're very smart, and they're using that brain on themselves rather than on something else. And when that happens, it's very dangerous. With the VOMs, we may see no provocation at all, or we may see some provocation. It's very important that if there is a vestibular component to the anxiety, you've got to treat the vestibular problem first and then attack the anxiety. But if you do the VOMs and it's totally normal, and their impact data is totally normal, how do we treat anxiety? We treat it by exposure. The way you treat anxiety is by actually going into environments that make you anxious. It's by getting back into school. It's by exercising. It's by desensitizing that anxiety. You're not going to get patients better with anxiety by putting them in a dark room. You're going to make it tenfold worse. And so again, this is another one of those profiles that if you don't actively treat it, you're going to end up with significant morbidity that can lead people to suicidality. We see patients probably every day that have some issues with suicidality because there's so much anxiety going on. And we got to be careful here with this discussion of potential long-term effects because it's leading people to have problems that are treatable. We can treat depression, we can treat anxiety, we can treat vestibular dysfunction. It's a treatable problem. Very scary that that's not being recognized. But the way we treat it is by exposure. Also, we do have medications to manage this. And patients that are anxious, we do not want them taking naps. We want a regulated sleep schedule. We want exercise. We want good diet, hydration. You know, we want them in social environments. We want them being active. Now, when we look at neurocognitive testing, this data gives us a really good handle on patients that are either anxious or anxious and have vestibular problems. Like this profile here, these are percentiles. This person is off the chart on neurocognitive testing. This is a patient who's anxious. Looking at that data, there's not much going on concussion-wise. Having this information really leads us down a path as to what's going on. If you have this profile, remember visual motor speed? See that 12th percentile right there? That's a patient who ended up having vestibular issues as well as being anxiety. So what I'm trying to say is the tools that we use, when you look at the VOMs, you look at neurocognitive testing, you look at what symptoms the patient are having, it can lead you down a pathway as to how to treat this patient. How aggressive can we be with exertion? How aggressive can we be with getting them back to school and all these types of things? The third type of problem following concussion that we see is ocular motor. The eyes are the most complex system in the brain. 65% of our neural pathways are devoted to eye movement. Our eyes have to work as a team. They have to move together. They have to converge, diverge. They have to work together in harmony. When concussion affects the oculomotor system, our eyes don't work together as a team as well as they should. And you can pick up on this in certain parts of the exam. You can pick up on the neurocognitive testing. And the symptoms that we see from oculomotor dysfunction are going to be a little different. These are patients that get headaches when they're doing math or science. Usually the headaches are frontal in nature, behind the eyes. The other symptom we see with oculomotor dysfunction is patients are really tired after doing schoolwork. They'll suffer with their reading. They'll suffer with math. They'll suffer with science. They get symptoms at the end of the day after pushing the visual motor system in school. This is fairly common in our patients. In fact, 42 to 69% of concussed athletes will have some sort of oculomotor problems following the injury. Now, the neurocognitive testing piece is very critical to understanding if there's an oculomotor problem. Memory's three things. Memory's encoding, consolidation, and retrieval. When you look at the memory testing and neurocognitive testing, we present kids with stimuli immediately, and then we have them remember it 20 minutes later. If you have problems with the encoding and the retrieval's fine, you can see the pattern here that they are actually able to take in 71% of the information, and then they actually get back, more information than they took in for the retrieval. That is a very oculomotor pattern, because when you have oculomotor problems, you're not able to encode the information. You're able to retrieve it, but you're not able to encode it. And so looking at this information in the neurocognitive data, as well as looking on the VOMs and looking at the neuroportin convergence and looking at their saccades and pursuits and looking at their symptoms, you start to identify, oh, there's an oculomotor problem here, okay? And we could spend a whole day going over this model and how we assess this and how we treat it. I'm trying to present this in a fairly coherent, quick fashion. There's a lot of depth to treating concussion and understanding what you're actually treating and how to treat it. But if you send a patient with concussion to our clinic, we have all kinds of tools to understand these issues. And we can look at this stuff in a pretty sophisticated way. How do you treat oculomotor dysfunction? Guess what? It's not by rest. It's about expose, recover. You have to retrain that system as well. You don't get better from this until you start doing some form of reading or some form of math, and you retrain the system to know how to converge vision, diverge vision. There's very good oculomotor exercises that Ann will talk about today that teach patients how to retrain that system. This is not about avoidance. This is about expose, recover, just like every other circle I've talked about so far. Exposure, retraining, rehabilitation. These are words to live by as it relates to concussion, not sit in a dark room and do nothing. And again, that's what's been proselytized in the international consensus statements. It's not the way the injury works. It's about rehabbing it. The fourth type of concussion that we'll see is cognitive fatigue. And quite honestly, this is the type of concussion that's the hardest for us to treat. And this is the reason why is because these are patients that push through vestibular dysfunction. They push through oculomotor dysfunction. There's a window of opportunity to treat these problems. And if patients aren't taken off the field, and they're not managed with concussion, if this is not recognized, these are some of the patients that really worry me about their lectures this morning. These are patients that I'm not a strong believer in sub-threshold concussion. I actually think if you ask the right questions, use the right tools, understand how to look at this injury, these injuries are pretty threshold. We can see problems. But there's some patients that don't report those problems. There's some clinicians that don't know how to look at those problems. There's some kids that don't get this recognized. And those kids that push through these issues, we can end up seeing chronic fatigue. We can see memory problems. In other words, there was a point in time in this type of concussion where it was treatable, but that window didn't happen. And we don't have an easy treatment for these issues. We can see it in our testing because retrieval plays more of a problem than encoding. It's the reverse pattern that we see from the oculomotor problems, whereas their memory's impaired, okay, relative to their taking in information. These are patients that we know that they have a history of learning disability in some of these patients. That's a risk factor. The symptoms that we see is this cognitive fatigue at the end of the day. The patient is pushed through everything. There's general headache, sleep problems. There's emotional issues. There's this chronic fatigue type of thing. I don't know if maybe this is the cohort of patients with concussion that may potentially be at risk for these longer term issues. We don't know. We got to bridge that research, and that's why the stuff you're doing is so critical, but we have to marry what we're doing to what you're doing to better understand the phenomenology of the problems. And we'll often see, global deficits across the neurocognitive testing. But by looking at this data, we can really better understand this problem. Now, how do we treat cognitive fatigue? Not real well. Take breaks during the day. We can actually initiate some exertion with these patients that's helpful. It's supervised. We can work them out, and it may be helpful. A lot of times there's sleep problems. We have medications for that if needed. We can treat sleep hygiene, that kind of stuff. And in some cases, we can do cognitive rehab, but this is compensatory. It's not treating the problem. It's more compensatory, and we're teaching people how to work around their memory problems. So this is the type of patient that worries me the most as it relates to the conversation this morning. The other patients I've shown so far, we can treat those patients really well. And I think we can treat these too, but it's a little more difficult. The fourth type of concussion we see is migraine. And there's a lot of patients. I often say that if you don't know how to treat anxiety and you don't know how to treat migraine, you probably shouldn't be treating concussion, because these are two of the most ubiquitous problems that we see. And we also know that these symptoms predict some of the worst outcomes. Now, 40% of adolescents report experiencing post-traumatic migraine. These are patients that have headache with nausea, light sensitivity, noise sensitivity. Their headaches are usually worse in the morning, get better as the day goes on. There's usually a family history of migraine. There can be a history of car sickness, which predicts migraine, okay? This is usually more common in females and males, to your point, 4 to 6 times more likely and happen in females and males. But how do you treat migraine? You treat migraine by activity. You don't treat migraine by, now in the throes of a migraine, you're not going to be able to work these patients out, but to flush out the migraine, activity helps with that. We want regulated sleep. We do not want naps. We want regulated hydration, regulated diet. We want them to reduce stress. In our experience, the patients that have internal stress that don't express it very well are the patients that end up getting migraine after a concussion. And when you get migraine, a lot of times migraine doesn't occur until a week after, 2 weeks after the injury, when the stress builds up. There's a lot of anxiety. They may have been tell them not to use your phone. Don't use your phone. Take naps, sleep all day long. These are patients, when they get that information from a pediatrician or whomever, and they're given wrong information about how to treat their concussion, they do all these things that lead to migraine. Does that make sense to everyone? And once you get migraine, when that genie comes out of the bottle, it just adds on top of all the other problems that we see. And you got to end up cleaning up 3 messes that was just one originally if you didn't treat the patient, out of the gates the right way. So on the VOMs, you can see provocation in some patients and not in others. If you have a normal VOMs with migraine, the best way to treat that migraine is by working patients out. If it's an abnormal VOMs, you want to do vestibular therapy and sort of work through that and then work patients out. But activity is going to get these patients better. Interestingly, on neurocognitive testing, we see more verbal and visual memory deficits than we do some of the other domains on the neurocognitive testing piece. And again, how do we treat this? There are medications we can use. We find abortive medications aren't that helpful because a lot of times they're already in the migraine. Sometimes we can use preventative migraine medication. Amitriptyline is a good example of that. Sometimes we have, if the mood is driving the migraine, sometimes we use an SSRI like sertraline to get that under control, and that helps the migraine. Depends on what's driving the bus. But again, regulation is key. Regulated sleep, hydration, diet, stress, exercise. As clinicians, I would advise you, when you have patients with concussion, I don't want them napping. I want them in a regular sleep schedule. Go to bed same time, wake up same time. I want them walking. I want them doing some form of exercise. If there's a big vestibular component to it, you don't want to do too much dynamic movement. You need to be careful with that. But every patient can walk after a concussion. We want them in social environments. We want them in busy places. We don't want to take their phone away. And so, those recommendations are going to lead to less morbidity in these patients. And it's very important to understand that. So really, in summary here, this is our whole model. You have certain risk factors that you bring to the table. You take a blow to the head. You head down these different pathways. If you go to the right clinic and you know how to match the right treatment with the right problem, and you do it in a targeted way, we can get these patients better much faster. I look at this injury as very treatable. And sports are a wonderful thing for kids and human beings. And I think we got to be careful in promoting that as much as some of the concerns we have about the injury as well. But I do want to point out, though, that to treat concussion, you need a multidisciplinary program to do it. It's becoming more and more of a specialty area. In Pittsburgh, we get referrals from these different areas. We're the point guards, but then under the same roof, we have all these specialists: primary care, sports medicine, PM&R, vestibular therapy, exertion therapy, orthopedics as neck issues, neurosurgery, behavioral optometry. We have 35 faculties and staff as part of our program. When I see a patient, I'm going to do the evaluation, but I have my treating specialist, my vestibular therapy, my exertion therapy, all together, because that's the only way you're going to be able to treat this is by that multidisciplinary care. And that's why it's so critical that in Ireland we create these specialty clinics, and that's happening right now. And it's very exciting that that's occurring, because those are the places kids should be going to receive the treatment, because it's very complex. The last slide I want to show you is I just want to share with you that this information I've shared with you today has been agreed upon as the appropriate way to go in managing concussion. We were a little bit, given the fact that there was one sentence in the 2012 International Consensus Statement as it regards to treatment, we wanted to convene a meeting in Pittsburgh of world experts on treating concussion. We invited 37 experts around the world. We had a statement of agreement meeting on treating concussion, and that information was published in Neurosurgery in 2016. And in that paper, we agreed on 18 statements of agreement. And you can see here some of the statements. It's all the stuff I've just talked about. You have to match your treatments to your problem. There's active treatments available. And probably the most important thing we agreed upon in this paper is that concussion is treatable. Imagine a day where a kid comes into a physician's office, they sit down with their parents, and you say to the kid, yes, you've had a concussion. This is the type of concussion you have. This is probably how long it's going to take to recover from that injury. This is the rehab you're going to do. It's going to be done in a very active and targeted way. And yes, you're going to get back to the sport that you love. I think that conversation is a little bit less scary than some of the things I'm hearing about this injury. And I feel that we can achieve that very well in terms of managing this injury. And I hope that conversation evolves more and more over here in Ireland. And I think it is, with the help of Bon Secours and the GAA and what they're doing to support this work. It's phenomenal. So in summary, get kids off the pitch when there's symptoms of concussion. That's easy. That's the easy part, okay? When in doubt, get them out. Dizziness, 6.5 times more likely to predict problems. I mean, the pitch stuff it's not easy. I don't mean to marginalize that, but get them out of play. Understanding that referral to a concussion specialist is important. Clinical profiles of the roadmap and multidisciplinary teamwork is key. Know how to use your tools. When you use neurocognitive testing, know how to do it. Know what questions to ask. Know how to do the VOMs. Know how to look at this injury in a sophisticated way. The secret sauce is the right amount of activity, behavior regulation, and matching the right treatment to the right problem. Expose and recover are words to live by, more so than rest. Expose and recover is a whole different way of looking at this. And it's going to be effective the great majority of the time. And lastly, again, this is a treatable condition. So with that, I thank you very much. And again, thank you so much for the opportunity to present. Appreciate it.